This week on the BackTable Podcast.
I don't know that this is based on any real evidence, and it's just kind of how it makes sense in my mind, but I want their bladder to retrain itself. I feel like adding in a beta agonist or an anticholinergic is just putting a Band-Aid on a wound and not letting it heal. And I want them to have to, I hate to say this, but to suffer through that period of the urge incontinence so that they can retrain.
Hello everyone and welcome back to BackTable Urology Podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at backtable.com. Now, a quick word from our sponsors.
From concept to completion, there's a lot to consider when building a Theranostics or PSMA PET-CT imaging program. It's nearly impossible to be an expert in every aspect of this care pathway, but the success of your program depends on it. Get the support you need from an experienced team. Open your web browser and search Siemens Healthineers Theranostics. You'll see the complete Theranostics care pathway and how they can help you customize it to meet the needs of your prostate cancer patients. Visit their website or stop by Siemens Healthineers booth at the local and national American Urological Association and large urology group practice association meetings. You deliver the care, they'll deliver the rest.
Now, back to the show. This is Jose Silva as your host this week. Today we have Dr. Spencer Hiller. Dr. Hiller did his medical degree at the University of Michigan, then went on to complete a urology residency at William Belmont Hospital. He then returned to the University of Michigan for a 2-year endourology fellowship, specializing in complex kidney stone disease management and treatment. Currently, he practices in Advent Health Orlando and brought HoLEP to this area. Spencer, welcome to BackTable.
Thank you, Jose. It's an honor to be here.
How long have you been with us? Almost 2 years now?
About a year and a half, maybe a little bit more.
And in that time, you really have become the guy to go for HoLEPs in the area. And so before we dive into HoLEP, just tell us your background in BPH, how was in residency, how it changed in fellowship, and just your background on BPH.
Probably not too unlike you. During my residency, TURP was the gold standard, at least where I trained, for BPH surgery. My choice to do a endourology fellowship and the one that I eventually completed had nothing to do with HoLEP. I was really excited to do PCNLs, and it was really just a afterthought that I would also learn HoLEP while I was there. And if you want me to be completely honest, I wasn't really that excited about that aspect of things at all. I had heard of HoLEP, but I didn't believe that it could be anything better than, to me at the time, what was the gold standard of TURP.
Because I remember when they interviewed you or in the process of trying to get you here, I was hearing just, we're going to bring this guy doing the complex PCNLs, all the bad stones, different anatomy. So I never heard, hey, we're going to bring this guy to the HoLEP.
Yeah, and it really was only after seeing and doing maybe the first 50 or so during my training that I really started to believe in it and saw the benefits of it. You know, I had more exposure than most currently to open simple prostatectomies and seeing the results from that. And it was only with the training during the fellowship that I really saw how much patients really benefit from a HoLEP.
And during training, were the attending was doing HoLEP for big stones, small stones? It was just the only thing he was doing?
For BPH?
Yeah.
So I trained at University of Michigan for the fellowship, and I learned from Casey Dow, who was really a great guy to learn from. And his thought process is that he's running a HoLEP training program. And so to him, every BPH procedure is a HoLEP, but he's also at a tertiary referral center And so everybody that he's seeing is either a PCNL consult or a HoLEP consult.
And that's essentially why you have become here, right? More or less?
Yeah, I really did not think, because I chose to not go into academics, I did not believe that I'd be able to build a referral type practice where the majority of what I'm doing and seeing is really big stones and big prostates. I do remember when I was trying to decide on jobs, talking to Casey Dow about this and asking him about his experience and how he was able to market himself. And I remember he said exactly, if you do HoLEP, the patients will find you. And it's really true. I mean, I have tons of patients that just found me on the internet because they heard about the surgery and they're there for that reason. They say, I've been waiting for you for years.
And right now, is the hospital doing the advertisement, or it's mainly you yourself, or word of mouth?
I've been pretty fortunate that I've had very supportive partners that, when I first got here, just screened patients for me and sent them my way. There hasn't been a ton of marketing really that's been required, or advertising that's been required. I think once I showed that I could do it at a high volume, the patients just kept showing up. I don't know how else to say it.
And it was during the fellowship that doing complex PCNLs and being a referral center is what I want to do.
Yeah, PCNL was the first urologic surgery I ever saw. And I remember vividly that it was just eye-opening to me. I didn't think that something like that was possible. And I knew right away that I loved PCNLs. And that's why I did the fellowship, was I wanted to do complex PCNLs and be, cutting edge with that. And HoLEP was just a second thought within that.
So I'm going to echo. So the same thing happened to me. So I wanted to do orthopedics until I did a rotation in urology. And PCNL, I said, are you kidding me? We're in the kidney? I mean, for me, it was like seeing a video game. And you're trying to go into different pockets in the kidney and just make sure there's nothing there if there's a stone blasted. So yeah, pretty cool procedure.
It comes full circle for me that as a med student, that first PCNL I saw was with Casey Dow, who eventually became my fellowship director as the resident, and the infamous Stuart Wolf as the attending in the case. And it's an experience that I kind of will never forget.
Awesome. So let's talk about who's a candidate. I mean, once the patient gets there, I mean, is there something different that you speak to the patient versus when you were residency talking about TURP?
So most of my discussion with the patient before surgery is related to the mostly transient incontinence that occurs after HoLEP. And it's something that I really worry about every single case is, how long is this guy going to leak for? So I prepare every patient to say you might be in the 1 or 2% that leaks permanently. I don't expect it. What I do expect is that you could leak urine for up to 12 weeks afterwards. And that's usually my threshold for timing that I say, we're beyond the expected short-term leakage.
And when you're talking about leakage, you're talking about stress incontinence.
Well, that's a really good question. And I think it's a little bit of both. I think there's a huge urge component related to this, and just most of these guys have very strong bladders. And when they get an urge to urinate, their external sphincter, which they've never used, aside from maybe trying to stop the flow to go answer the doorbell or something, is not strong enough to overcome how strong their bladder is for the 75 years it's been working. I think a lot of the leakage has been historically with HoLEP attributed to weakness in the external sphincter related to the surgery, which I think is true. But I do think that there's a big component just related to urge and the inability to adequately stop that external sphincter.
In terms of Kegels, I mean, preoperative, for example, is that something you tell the patients that they should start doing it?
Yep. Everybody gets a Kegel exercise handout from me, be it either pre-op or post-op. And I tell them when they are leaving the hospital, if they've not already started Kegels, to start doing them day one. And my standard is that when I see them post-operatively 8 weeks after surgery, if they're having any leakage and they're bothered by it, I will refer them to pelvic floor physical therapy. I'm pretty aggressive about pelvic floor physical therapy. And if they contact me before that 8-week time point about leakage or bother from it, I will go ahead and refer them to pelvic floor physical therapy.
And when you're talking about that patient in terms of the stress incontinence, I mean, why do you think that happens? Just because the aggressive nature of the opening that you're creating with the HoLEP?
Yes, is part of it. I think most guys don't know how to work their external sphincter like they need to after a surgery like this. You know, when you're trying to explain to your average patient that the Kegel exercises are simply to strengthen that muscle so that it can get you to standing over the toilet when you have that urge, they have a hard time understanding that they have to squeeze that muscle the whole way there. Maybe 6 months, I didn't really piece it together that most guys, when they're doing the Kegel exercises, think that all they have to do is be squeezing it sitting on the couch. And then when they get that urge to urinate and they stand up, they didn't understand that the whole point of the exercise is so that they have sufficient strength in their external sphincter to get them to the toilet. It's a lot about patient education. I draw a lot of diagrams for patients and talk to them about this extensively. And I think some people it sticks, some people it doesn't. And that's where physical therapy really comes in.
So how do you tell the patient to do the Kegels? I mean, what's the correct way of doing them?
I will usually tell guys to figure out what muscle you're supposed to squeeze. I want you, while you're urinating, to stop the flow of urine and cut it off. And when they're able to do that, I say you've found the muscle. Now, when you're sitting on the couch, riding in the car, even right now during a conversation, I want you to squeeze that muscle 10 times and do that 10 times a day, if not more.
Okay, so the transient leakage, incontinence, is essentially weakness of the sphincter, not really related to damage to the sphincter.
I don't know if I would go so far to say that there's no damage to the sphincter. So there's a lot of technical things that I've tried to incorporate in how I do this procedure to try to minimize damage to the sphincter. And there's a lot of discussion in on-block HoLEP or early apical release in liberating that distal part of the adenoma off of the sphincter as early as possible to minimize the trauma. I will say that for the listeners, there's definitely some trauma. My hope is, and what I'm trying to achieve, is that it's transient damage, not permanent damage, but it's hard to say.
Because I think with other techniques, TURPs, green light, aquablation, I mean, you're always afraid of that area. It's a trade-off between being very aggressive and not having to do another BPH surgery on a person versus being less aggressive and maybe having to go back and just shave a little bit of those apical tissues. So I guess that's always the question, how much to take off. But when you're doing a HoLEP, you're essentially removing most of what you can see.
It would be hard to leave that distal tissue that you traditionally leave with a TURP. You rely on that anatomic plane, and trying to bypass it distally to leave a little bit of that apical adenoma would be tough. I mean, there are certainly people that do it, but it would be difficult. I mean, I remember with TURP that it was, you do not go past the viru. And so the first time that I saw a HoLEP, I mean, my jaw was on the floor in terms of how far beyond it you can get sometimes. So when you see it like that, you have an appreciation for why they leak immediately afterwards. But I think I have found with adequate education, patient counseling, and just being truly frank with patients about it's unlikely to be permanent, but likely to be present transiently. And most guys appreciate that and are okay with it. Some of that's just because most of the guys that I'm treating are living with a catheter at that point. And so they say, if it gets me catheter free, I don't care. But I certainly wouldn't say that I have nobody that leaks long term, but it's not many, if you want me to be honest. I mean, I try to keep track of that. And I don't know that I've had, as far as I'm aware, anybody that's chose to move on to a sphincter or a sling because of their bother from the leakage.
And in terms of other side effects, retroejaculation, is that something that's going to happen?
It's a certainty. I've had a couple guys that will want to try to preserve it, and I've done handful of median lobe only enucleation. I don't think they have anywhere near as good improvement in their urinary symptoms. And of the maybe 20 or so guys I've done it for, I think it has maintained antegrade ejaculation in maybe 70% or 80%.
So it is possible. In terms of patient selection, I mean, let's say a patient has prostate cancer, or a patient prior to radiation, or is on active surveillance. Have you seen those type of patients?
Yeah, I've been surprised the number of referrals for really big prostates on active surveillance, or they've been on a chronic elevated PSA hunt and had 20 biopsies throughout their life, and they're worried about the possibility of cancer, or their urologist is worried about cancer, and the referral is to try to minimize or get rid of prostate tissue to make this screening easier. Now, I mean, I wouldn't recommend HoLEP for that alone, but if you add in some of the lower urinary tract symptoms that most of them have, it's been pretty successful from that standpoint. It drastically lowers their PSA and makes screening a lot easier afterwards. In the setting of prostate cancer or known prostate cancer, and they're moving on to a definitive therapy, typically radiation, it works very well in that setting. I struggle with, and I don't know that there's an answer to this, when to start the radiation afterwards. I've typically told guys, unless they have a high-risk cancer and we're really trying to push through getting treatment started, to try to wait until they're continent. Once they've stopped leaking, then they can go forward with the radiation.
In terms of the HoLEP technique per se, I mean, is in this case, I mean, is there a way of being less aggressive, for example, in those patients trying to preserve more of the tissue and trying to preserve continence versus being a little bit more aggressive or just let radiation take care of the tissue that is left over?
In the setting of cancer, and they're planning on moving on to a definitive therapy like radiation, I actually try to be as aggressive as I can in terms of tissue removal. I think of it like a debulking of their disease. Now, HoLEP, we always talk about we're removing tissue and leaving you with just the capsule, but it's not really the capsule that we're leaving. It's the peripheral zone of the prostate. We're just removing the transitional zone. And so most of the cancers are located not in the specimen that we remove. And the guys that do have cancer, and I'm treating them before they get radiation, I've been surprised at how few of them have cancer in their specimen, actually. Now, it's the guys that we weren't expecting to find cancer, and they come back with some low-volume Gleason 6 or low-volume Gleason 7 that I'm constantly surprised at. But to answer your question, I mean, I don't really change anything. Maybe I'm a little bit more aggressive if they do have cancer to try to get out as much tissue. I don't know that that's the right thing or not. I do try to talk to guys about their concern for leakage, and say somebody's really, really concerned about leakage, then maybe I try to be a little less aggressive. But that would be true for a cancer or not cancer scenario.
In those patients that, I mean, the elevated PSA, multiple biopsy, everything has been negative, then you do a HoLEP. I mean, just like the TERP or some, that patient comes back positive for cancer, and let's say it's a young guy, candidate for robotic-assisted prostatectomy. Is there a difference in terms of outcomes? I mean, or ease of the surgery? Have you talked to...
Everyone that I've talked to about it may be too scared to do a prostatectomy after a HoLEP. And I think there's just some concern, especially if there's maybe a capsular perforation, be it small or large. Maybe there's more inflammation and the actual removal would be a little bit more difficult. I don't have any personal experience with it. And anytime I have tried to move them on to, say, a prostatectomy, they've been deflected over to radiation. It'd be a good question for a high-volume prostatectomist out there.
Yeah, I didn't know the answer, so it might be just like the energy.
I absolutely remember during my training, prostatectomy after a TERP, there was definitely some more inflammation. I mean, it certainly wasn't impossible, and we did it. What's nice with the holmium laser is the tissue penetration is far less than what you would see from the bipolar cautery. And so I would expect it might be easier, but that's not the sense that I get from those that do a lot of these.
I'll have to ask one of the partners.
That'd be a good question.
So Spencer, so what do you need to start doing HoLEPs? I mean, definitely from what you mentioned, it's not as easy as just watching a video, but let's start with what equipment do you need?
I use a Storz tower and scope, mostly because that's what I was trained with. You're using a traditional resectoscope sheath. I use the 26 French sheath, although I was trained with the 28 French. And when I arrived here, there was the typical, everybody loves the term supply chain issues. I was somewhat forced to start with that 26 French, and I adapted to it, and I actually like it more now. So it's just a traditional 26 French resectoscope sheath. There's a laser bridge that's used, and you need to have a nephroscope with an adapter that can hook up to the resectoscope. So the nephroscope is, during the morcellation, you exchange the laser bridge out for the nephroscope. On top of that, most people these days are using Moses laser is latest and greatest. I don't have any experience with the thulium for enucleation. I have a very small amount of experience with the thulium for enucleation, but certainly that's done. So you need a laser, you need a resectoscope, you need a nephroscope, and it's the side channel nephroscope, and a whole lot of saline irrigation.
And in terms of the laser, side firing laser as well, or just a regular stone laser?
Nope, it's a regular. I use the 550 Moses fiber.
Going bigger for 1,000. I mean, is there a difference, or?
The reason that it's not really necessary is, number one, I mean, we can achieve the necessary power outcomes with the 550, but you'd also be compromising your flow in some way. I use this laser ureteral catheter to help stabilize the fiber, made by Cook, that I think a lot of people use, that I don't know that 1,000 fiber would fit through there. So I would worry about compromising flow in some way.
Yeah, because I mean, I use that same technique, but for big stones for the cytolytic apaxi, but I use the 1,000 because it's so big. You don't need stabilizing when you're using compared to the 500. But I mean, if you're doing a great job with the 500, then don't mess that around, right? So in terms of bleeding, do you need to do a specific setting on the laser so it doesn't bleed?
Yeah, so my settings have evolved with time. I was trained for the enucleation using a setting of 2 joules and 30 hertz, for coagulation using a setting at 2 joules and 20 hertz, but that's on long pulse of the laser. I've changed a little bit where my nucleation setting, I've gone up in the power I find myself more efficient at 2 joules and 40 hertz. And then for coagulation, I've actually gone down to 1.5 joules and 20 hertz. there's a lot of different settings that people use out there. I mean, it's a surgery that I'm really passionate about. And so, of course, I followed tons of people on Twitter or X, what's posted. And there's a lot of different settings that I see used. And I've tried to adapt and try new things. That's one thing that I will say is starting in practice and building a HoLEP practice down here has required me to be very flexible with the scope I'm using, the laser I'm using, catheters, post-op management, and it's important to constantly be trying new things, and I love watching videos and trying something out the next day to see if it can help improve outcomes for me.
Yeah, I mean, you're the only one doing it, so it's not like you can go to the room next door and ask them. So,
yeah, I mean, of course, this is all in the interest of trying to improve outcomes, not worsen them. I mean, I don't know about you, but I remember during my training, that some of my favorite attendings were constantly watching videos of other people operating, and I kind of didn't understand it at the time. I totally get it now, where when I get into bed at night, I will typically put in my headphones and watch somebody else operate for 30 minutes before I fall asleep. I don't know if that's weird or not, but I'm sure there's others out there that do that.
Especially, I forgot to ask you in terms of the pre-op, any mandatory or optional testing that you're doing for these patients?
Yeah, I really, really like to have a accurate size estimation, be it an ultrasound, MRI, a CT of the pelvis, and then they need to have had a cystoscopy at some point. Because most of these patients are referrals from others, most of them have had a cystoscopy already. And I don't require, I don't repeat it unless something seems amiss to me. They've got a small prostate, but they've got terrible symptoms. So long as things are kind of adding up, I don't require a repeat cystoscopy, but I do really, really like to have some kind of a size estimation. I've had a couple circumstances where insurance wouldn't approve ultrasound, wouldn't approve a CT pelvis, wouldn't approve an MRI, and I've just had to go ahead based on a cystoscopy. But for the most part, they have that.
Yeah, for aquablation, for example, I'm having each specific insurance that they need to have an ultrasound of the prostate. If they have the MRI, that's not the equivalent. So
does it have to be a transrectal ultrasound? That's a tough sell for a lot of guys.
But yeah, and I talked to the supposedly we can do it in the OR at the same time and then put it in the note but it's a little bit more time in terms of the workup or trying to get these patients into the OR. So Spencer, going back to the technique, I mean, your technique has it changed since you started seeing them back in the fellowship?
Yeah, there's a lot that's the same. There's a lot that's different. So the very first thing I do is release the apex of the prostate, which is not something that I was doing during the training. If the prostate's not too big, I will start doing it en bloc, meaning rather than the traditional 3-lobe or 2-lobe technique where you start with an incision at the bladder neck and carry it all the way out to the apex of the prostate. If I have a good view and I feel like I have a good sense of where I am in the prostate, I can carry on that apical incision proximally and not have to, after incising the apex, return to the bladder neck and just kind of do this standard 2-lobe or 3-lobe technique. Especially for anybody training, it's really important to have your default safety procedure or backup, because I still have times where I'm struggling to find the bladder neck anteriorly or struggling to get over top of the prostate, and I have to resort to the traditional way that I was trained. So I mean, this goes back to the flexibility thing. I think it's just important to be flexible and be constantly adapting. Everything that I do or any changes have been in the interest of trying to cut down on that incontinence risk, to be honest.
So it's not about time, it's about result.
Yeah, if you want to be honest, I mean, I really try to minimize the trauma distally as much as I can.
Describe how you train. I mean, is it you start like just like a green light, doing channels as 9 and 3?
So if guys have a big median lobe, I mean, the median lobe is perfect for learning how to do it in enucleation. And you'll start with a incision at 5 and 7, and you carry it down to the bladder neck, and then carry that distally, basically to just proximal to the verumentanum or the ejaculatory duct, and get underneath it. I remember the comparison was like, imagine a seal balancing a ball on the tip of its nose. It's just an image most people can understand. And that's really how you carry your incisions more proximally and then flip the lobe into the bladder.
So you start at 5 and 7, go down to the veru, and then you start undermining that tissue and bring it up. Okay.
And that's how you would do the traditional 3-lobe technique. So if that's if you're doing that median lobe separately and then going to move on to the lateral lobes. Most of the time, if I'm not trying to do an en bloc, I will make an incision either at 5 or 7 and carry that all the way to the apex of the prostate, to that initial incision I made just proximal to the sphincter, and then carry that all the way around.
And then you go high on the laterals, 11 or 1.
So when you get to the lateral lobes, you've made like an incision in that fold of the lateral lobe, just lateral to the verumentanum. I wish it was prettier than this, but it truly, you park your scope just kind of right over the verumentanum, and then you shove your hands in one direction. And it always finds that perfect plane. It's a kind of a perfect way to find out where you need to go.
In terms of the sphincter, why do you think going apex first versus the traditional how you were trained?
So if you're not making that initial incision, the most distal part of your enucleation is done bluntly with the scope behind where you can see. So you're carrying it around, but you can't see where the back of your scope is actually tearing that tissue. And, you'll finish it and look.
So it'll be like if you're doing an open simple with your finger, not seeing where you're actually pulling it out.
Right. So, doing an open simple and rather than that kind of pinching that you do at the apex, it'd be like just pulling it.
Okay.
And it tears where it tears.
Interesting.
So you get to decide where that apex of tissue remains.
So once you have the lobes in the bladder, you remove the scope and then go in with the nephroscope.
So yeah, the sheath stays in, but everything else comes out.
So the 26 sheath of the okay, so it's the inner part. Okay.
Yep, and then there's an adapter for the nephroscope to that 26 sheath.
And why is that? And why do you need the nephroscope? Just the channel's open, it's bigger?
Right, so you need a straight, wide channel because the morcellator probe is a metal rod.
Just like the PCNL?
Yep, yeah, it's very similar in size and shape to, say, that, the shock pulse or the Trilogy probe.
And then anything specific that you need to watch out when you're doing the morcellation in the bladder?
Yeah. Watch out for that bladder wall. So, I mean, I have 4 bags of fluid going, and 2 of them going into one channel, 2 of them going into another channel. All of the outflow is through the morcellator. If I'm at all concerned about how full that bladder is, I will turn off the suction on the morcellator and let that bladder fill until I can feel it. That's the only time that I can really harm the patient during this procedure, is if I let the bladder collapse. I'm very strict about the fluids. And I mean, every single time I make sure that the second tubing that I just started with the morcellation part of it, making sure that roller ball is open and they've unclamped all the bags, and constantly have somebody trying to sabotage me. I have to be very vigilant.
So talking about the bladder, making sure is full, if the patient starts coughing.
Usually because they're so full, it's not a huge deal. But I will, communicate with the anesthesia colleagues at that point to say, hey, this is a dangerous time. Now, it's unfortunate because that's when I'm closest to being done with the case and I'm telling them to make it deeper, but so be it. The name of the game is to try to pull the adenoma into the fossa. The fossa is not going to collapse around you the same way the bladder would. And so, worst case scenario, if the bladder did collapse, they had a bladder spasm or fluids ran out. If you're in the fossa, in general, you're safe.
In general, how long does it take to do the morcellator part? Let's say you can get the tissue inside the fossa. Everything is good, perfect. How long does it take?
It's very size dependent.
Tissue density is not important. It's about size.
Tissue density definitely makes a difference. And you will occasionally get these very rubbery, hard balls of tissue that are like a beach ball just bouncing around in there, and the morcellator can't grab a hold of them. It's hard to control for that and to prepare for that. When that occurs, you can slow down the rate of the morcellator, the rate at which it's chewing the tissue, so it can get a little better hold on things. I've had it occasionally where, after multiple attempts and longer than I'd like to admit of trying to morcellate these beach balls, where I will just grab it with a laparoscopic grasper and pull it out with the entire scope. I've never had to do this, but I know that people will sometimes leave the tissue and say, I'm going to bring them back in 5 days, a couple days later, and the tissue will have necrosed enough at that point that you can get a good grab on it. So you just leave them with the catheter until then.
And it's just because of time?
If it's a huge chunk of tissue and you've just spent forever trying to grab it, you just say, all right, you'll have a catheter for a couple of days, we'll bring you back, and it'll be nice and soft then. I've never had to do that, but that's kind of a last resort.
But it is something extra in your bag if it comes to that. So in terms of the post-op, anything else you want to address while you're there with that patient doing the procedure?
I spend a fair amount of time before morcellating, making sure that things are hemostatic. I mean, having seen and done a lot of TURPs during my residency, the bleeding at the end of the procedure is a lot less than what I traditionally saw. I mean, I don't know for you, but, a lot of these guys went on traction after a TURP. At least that's how I was trained. And I mean, it's very rare that I'm putting somebody on traction after this. I won't tell you it never happens, but it happens sometimes. But for the most part, it doesn't. Overall, the bleeding risk is very low. So I spend a lot of time making sure everything's nice and clear at the end, I guess, is the only thing that I would add.
In terms of having patients on blood thinners, is that something that you're doing?
Yes. And it pains me every single time I do. You can do this surgery while on blood thinners, and I have done it. I've done it on heparin. I've done it on Eliquis or Plavix if I had to. I've had a couple very well-informed patients that could not come off of their blood thinners for one reason or another. And I mean, the discussion I have with them is that, I mean, you need to accept that, you would rather potentially die than have to live with the catheter any longer. And you're okay with going forward with surgery. Anytime I've done it with them actively on blood thinners, the surgery itself is not bad. I can get good hemostasis, doesn't take that much longer, and it works pretty well. It's the afterwards. I'd say 50% of them have to return to the OR for one reason or another, getting rid of a clot or getting some hemostasis. So I really try to not do it. It depends how long it's been since I did it last and how traumatized I am from it.
In those patients, doing like the TURP and putting them on irrigation, put them in a traction, might that work?
Yeah, and I do it, but I don't know. Maybe I'm doing something wrong with it, but I don't enjoy doing it with them actively on blood thinners. I think most people would agree with that. Those guys, I really, I'll try to get them to get a prostate artery embolization or some other option, or wait.
So you're finished. So what type of catheter do you use?
So I'll leave everybody with a 22 French 3-way, not the hematuria one with those metal ribs, just a regular 3-way. I'll put somewhere between 50 and 70 cc's in the balloon. Typically, just some of it's just a subjective feeling for kind of how big their bladder neck is at the end and making sure that it doesn't pull in there. I will send probably 50% of my guys home that same day, and we'll do a voiding trial before they leave.
The same day? So they're leaving, they're going home without a catheter?
Yep. And then the other 50% will spend the night with the catheter, and then it comes out in the morning, and they go home without a catheter. It's very rare that guys have to go home with a catheter.
And is it based on size or based on anatomy, or a combination of both?
Whether or not they stay?
Yeah, or the fact that they stay with a catheter or not.
Honestly, the reason that they stay is time of day that the surgery happens. I mean, I'm doing the voiding trial for most of these guys myself, and if it's late in the day and I don't have the ability to come back in and do the voiding trial at night, so I'll offer it to my first couple cases of the day, but once we get into the afternoon, it's just going to be too late, and most of them don't want to have to drive home and at night, or have their wife drive them home at night where it's dark.
Exactly, yeah. Before I was doing a lot of green light, they went home with a catheter. Next day, voiding trial. Now with doing more of the aquablation, they stay at 2 days with the catheter, and that's what I was doing for TURP. So that's what I've been doing now.
I don't know how it is for aquablation, but I mean, I know that it's rare with the voiding trial that it has to go back in. Are you doing that in the office or in the hospital before they leave?
It depends. If sometimes they leave alone, they don't want to leave with a catheter, I keep them for two days, and then I do it there in the hospital. But if not, next day they go home, and probably start trying to get them discharged the same day, and then come back to the office 2 days after to remove the catheter. But we'll see how that goes. Like you mentioned, I mean, you're doing the voiding trial yourself, getting the hospital training and everything to give them irrigation for a few hours, and then seeing if they can be out the irrigation. It's going to be challenging to train the personnel. So we'll see how that goes.
I've been very protective over the actual voiding trial process of it since starting down here. Where I trained, they had a whole army of PAs that had been well trained by my fellowship director on the voiding trial. And when I got down here, I was very protective over it, and I do actually think that it makes a little bit of a difference. If their urine looks appropriate, I'm inflating the balloon, I'm irrigating the bladder, I will pull back the catheter into the fossa and pretty aggressively irrigate the fossa to make sure there's not a distal clot that when I take out that catheter is going to plug them up. And then I will fill them, to capacity and take it out. And what I really want is them to have a pretty strong stream immediately as soon as that catheter comes out. And I've been surprised how often, even though I tried so hard to get rid of every little blood clot in there in the fossa, there's still something that comes out when I do that. I found that it works pretty well. Now, do I have to do all that? I don't know. It's just kind of what I've found works for me.
No, you sleep better than knowing that that patient voided instead of going home and see what happens. When you train, that's what they were doing, or that's something that you started doing yourself?
I don't know that during my fellowship I did any of these voiding trials that I can remember. That really wasn't part of it. So that was something I had to figure out when I got down here.
Why did you start doing it just like did that voiding trial the same day to be different? You heard it, other people are doing it. So what made you try to do that?
So, same day discharge for HoLEP is definitely a known entity. And some people have published criteria. Most of the literature that comes out regarding HoLEP comes out of Indiana, although I guess now Northwestern as well. And, there's certain criteria. I honestly don't really follow a certain criteria. A lot of it is just an eyeball test. I mean, does this guy look like he could go home from the hospital the same day as surgery? And if I don't think that they look like they would do well at home, then I say, you should stay. And then some of it's just how their urine looks, if they're bloody. And we can always pivot to having them stay. It's hard to get them out the same day if they're already up on the floor, though.
And in terms of the Foley, I mean, is that something that you started doing also, that's the trend, try to remove those catheters same day?
Yeah, I'm certainly not the first person to try that. We dabbled with it a little bit in my fellowship. During the second half of training, I know that there was some of the first studies coming out of Indiana with some criteria, and so we tried it out. You have to have a recovery area that's willing to have these patients sit there on irrigation for a while. I'm fortunate that hasn't been a problem for me. It was actually a little bit of a problem in my training and figuring out where these patients would sit for a couple of hours on the irrigation afterwards. Sometimes it's not that long, though. I mean, I have some guys that are on irrigation for just like an hour, and then they're ready. I mean, they're crystal clear and they're awake and they want to go.
Cool.
I did see, I think it's Amy Krambach had some criteria where, she has them walk before she will do the voiding trial. I have not been able to figure out how to get the patients to walk before I'm, especially same day, able to remove it. I don't know how that would work. I mean, I really try to have these guys stay in bed while they have the three-way in on the irrigation, but it's something that I think about trying to figure out.
I guess it will be to see if there's some bleeding or something, so that it bleeds before.
I think it maybe increases their chances that they're going to be able to go because they can stand up to urinate. I mean, nobody urinates well laying flat on their back, so knowing that they're going to be able to hop out of bed, once that catheter comes out, I think that's probably the thought process behind it. But logistically, trying to get it done while they still have that three-way in and the irrigation tubing, I mean, it's always a mess in there when I'm trying to do these voiding trials of trying to untangle all the tubing and stuff.
And then in terms of, you mentioned the stress incontinence, everybody lives with a diaper?
Yeah, I tell them to be prepared for it. And the recovery area has something that, those big male diapers that we've all seen, or some of them come prepared with something from home. There are definitely patients that never leak a drop. Don't think that everybody is going to leak for 3 months, but most guys, especially that first week or two, are going to leak. And I think my experience is that number improves. I will tell them that approximately 50% of guys by maybe 2, maybe 4 weeks are mostly dry. And then that number continues to go up with time.
And in terms of the urge, when do you decide, okay, let's start some anticholinergics, beta-3 agonists, or is there a time, or is it just the patient that is calling you, hey, I cannot hold it anymore, or I'm going to urinate every half an hour? How do you decide which one to treat and which one just to wait?
Yeah, I really try to counsel these guys to wait. I don't know that this is based on any real evidence, and it's just kind of how it makes sense in my mind, but I want their bladder to retrain itself. And I feel like adding in a beta agonist or an anticholinergic is just putting a Band-Aid on a wound and not letting it heal. And I want them to have to, I mean, I hate to say this, but to suffer through that period of the urge incontinence so that they can retrain. And now there's a point where they say, hey, I'm having significant urge incontinence, and I try to tease out whether it's stress or urge. And if I really feel like it's urge, I will absolutely start them on something, but I try to wait at least 3 months, if not 6 months. I think more often 6 months.
I tend to give them something, even though I tell them beforehand, hey, this might happen. I explain, hey, your bladder has been contracting against a rug or obstruction. Now it's open. But I think they feel better if I give them a pill.
I think you're probably right.
I don't know, but it's true what you're saying. So I mean, I don't know what's right, but I guess in my mind, if I give them something, they and I tell, hey, it's just gonna be temporary. Maybe they feel that I care. Who knows?
I mean, I think you're right. There's pretty good evidence for doing Botox at the time of HoLEP for guys that have a lot of urgency symptoms. And I don't know that that's long-term data or not. I wouldn't say that I'm, well read on that enough, but I know that it works, and I've done it a couple of times and it works. I don't know that I'm doing the right thing with that. If you want me to be honest, in my mind, I feel like I should be letting them retrain their bladder. I don't know that giving them a beta-3 agonist really prevents them from doing so. So that's a good question. I don't know that it's right or wrong. Hopefully somebody will tell me.
I usually give them whatever I have in the shelf. I take this for a couple of weeks and we'll see.
Maybe I should start doing that. If you can't tell, I like trying new things. So
yeah. So Spencer, I think we covered a lot. Anything else you think we missed, we didn't touch?
It's been an honor to be on here. I love this podcast. I love listening to it. I do a trip with residents annually, and I know that there are a lot of residents out there that love listening to this. So coming on this and seeing big names that I've worked with in the past, like you just had Ganesh Palapatu on here, Todd Morgan, and people that have been influential in my career. It's an honor to be on here. So thanks for what you guys do.
It's an honor for me to have you, Spencer, and thanks for giving your time and your expertise. I mean, that's really it's you guys who are making this. We're just the medium.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.